النهارده هنتكلم عن two cases يعني not usually يعني we don't face عامة. أول كيس هنتكلم عليها النهارده في السيرجيكال يعني gastric teratoma patient. patient ده كان جالنا 35 days old. كان 35 days old patient, third order of birth, non-consanguineous marriage, complaining of vomiting, feeding, intolerance, and scrotal swelling. This condition started 26 days of life with vomiting, which was scanty bilious and not related to meals. The patient was misdiagnosed as testicular torsion and was operated as strangulated inguinal hernia. After surgery, the patient condition didn't improve. Still vomiting and epigastric mass started to be felt, was progressive and increasing in size. Pelvic abdominal ultrasound was done, first showing large heterogeneous epigastric mass and recommending CT pelvic abdominal with contrast. On examination, the patient was active, crying, and good suckling. Chest was free, heart, cardiac noise, normal S1 and S2, and no audible murmur. Abdomen, the patient has large distended non-tender abdomen. Investigations. The pelvic abdominal ultrasound showed large midline heterogeneous soft tissue lesion with internal cystic areas. Is seen at the epigastric region for better assessment by CT. CT showed well-defined soft tissue lesion at epigastrum with extragastric component measuring 8.7 centimeter and intragastric component 5.5 centimeter, mainly cystic with calcification suggestive of neoplastic epigastric lesion, mostly gastric teratoma. Alpha-fetoprotein was done, which was high, but beta-HCG level was normal. Here we can see the imaging mass protruding from the epigastrium. Differential diagnosis for this patient, we can assume mesoplastic nephroma, Wilms tumor, liposarcoma, retroperitoneal teratoma, gastric leiomyoma, and benign cysts such as pancreatic cyst, omental cyst, duplication cyst, and splenic cyst. What are teratomas? A teratoma is a type of germ cell tumor that starts in the reproductive cells and can turn in other types of different tissues as teeth, hair, fat, and muscle. The types are mature, they are usually benign, and mostly they occur during the reproductive years. Immature teratomas are usually malignant and usually occur among children. Teratomas can occur anywhere, but specifically ovarian teratomas, testicular and sacrococcygeal teratomas. This picture of ovarian teratoma, testicular teratoma, and sacrococcygeal teratomas. Etiology: teratomas usually develop when there are disturbances during the cell's differentiation process. It's sort of like that pluripotent cells turn into different types of specialized cells like hair cells, muscle, and bone. Symptoms: usually general symptoms include pain, swelling, and bleeding, but ovarian teratomas usually develop pelvic pain, abdominal lumps, bleeding, and urinary symptoms as urgency. Testicular usually develop testicular lump and pain. Sacrococcygeal teratomas, tailbone pain, abdominal pain, constipation, dysuria, swelling in the pubic area, and weakness in the legs. Complications usually include torsion, rupture, infection, and cancerous transformation. Diagnosis is based on medical history, symptoms, and physical examination, imaging studies as X-ray, ultrasound, and CT scans, blood tests to check the hormone levels and measure the tumor markers as alpha-fetoprotein, beta-HCG, and finally biopsy. Management: first step is surgical to remove the teratoma. Nearly all the teratomas require removal when discovered. Even if they are not cancerous, they can still grow or rupture, leading to other issues. If the teratoma is cancerous, additional therapies recommended as chemotherapy and radiotherapy. Usually, the vast majority of the teratomas are non-cancerous. In most cases, these tumors don't spread like aggressive cancers. As a result, most teratomas have excellent survival rates with early diagnosis and treatment.
صباح الخير، أنا رانيا مدرس مساعد جراحة أطفال في جامعة عين شمس. So our case turned out to be an interesting and rather rare case of a gastric teratoma. So gastric teratomas are extremely rare. They present less than 1% of all teratomas in children, and actually there is only about 102 cases of gastric teratomas described in the literature. Almost always they are usually benign compared to other teratomas such as the sacrococcygeal, mediastinal, and the gonadal teratomas, which have a 10 to 39% of incidence of malignancy. Usually gastric teratomas occur in infants in 94% of the cases, and they have a male predominance in more than 95% of the cases, as opposed to sacrococcygeal teratomas, which are more common in females. Usually they are not associated with any other congenital anomalies or any other syndromes. There's only been one case that was described with Beckwith-Wiedemann syndrome. So how can a gastric teratoma present? To understand how it can present, we have to know that there are two types. There is the exogastric type, which represents 60% of gastric teratomas, and an endogastric type, which presents 30% of the gastric teratomas. Most commonly, it is an epigastric swelling or a palpable abdominal mass in the epigastrium or the left hypochondrium, usually in the exogastric cases. Sometimes, if it is endogastric, it can lead to intramural extension into the stomach and ulceration of the overlying mucosa, which could lead to hematemesis and melena. Of course, the patient is going to have feeding problems, and due to the gastric outlet obstruction and respiratory distress due to the splinting of the diaphragm, there could be some non-specific symptoms such as fever and weakness and anemia and weight loss. Sometimes spontaneous rupture could occur, and the gastric contents will be leaked into the abdomen, and the patient can present with an acute abdomen. So how can we diagnose a case of gastric teratoma? As we said, it's a rare type of teratoma, and so it's difficult to diagnose preoperatively. But first of all, if a patient comes with abdominal distension, the first investigation we're all going to order is an abdominal X-ray. What might raise our suspicion is if we detect any calcifications, especially at the area of the epigastrium on an abdominal radiograph. And then we're going to proceed for a pelvic-abdominal ultrasound. Most of the mature cystic teratomas can be diagnosed by ultrasonography, but of course the modality of choice is to perform a contrast-enhanced CT, which will not only diagnose a teratoma, but also it will help us to detect the relation with the other organs, its extent, and its relation to the major blood vessels. Okay, so what are the different histological types of gastric teratoma? The most common type is the mature type, where histopathologically there is well-differentiated tissue. It is always considered benign, and it is given a grade of 0. The other type is the immature type. In the immature type, histopathologically, we have immature appearing tissue. It is graded from 1 to 3 according to the amount of the immature content and the degree of the mitotic activity. Malignant potential is present with the immature type. So what is the management of gastric teratomas? Complete surgical excision. Complete surgical excision is considered curative even in malignant cases. If we perform complete surgical excision for mature or grade 1 immature teratomas, this is enough. No further follow-up is needed. But for grade 2 and grade 3 immature teratomas, we need to follow up the patient with regular ultrasonography and alpha-fetoprotein to make sure that there is no residual or any recurrence or any malignant transformation. Prognosis of both the mature and the immature types of gastric teratoma following complete surgical excision has described to be excellent. Okay, so as we said, follow up with alpha-fetoprotein could help us post-operatively if there is recurrence, if there is residual tumor, malignant transformation. And it's important to know that only 12 cases of immature gastric teratomas were described in the literature. Actually, our case was an immature type. With the immature teratomas, a few of them in the literature showed that there has been malignant transformation in the post-operative period, and only one case of mature teratoma, there was a recurrence, but it happened after 2 decades from the surgery. So bottom line is follow up with ultrasonography, alpha-fetoprotein is advised. So what do we do in the surgery? Our aim in surgery is total excision. We should take also a small part of the gastric wall and then close it primarily. We should know that gastric teratomas can arise anywhere from the stomach, but most commonly they arise from the posterior wall and from the greater curvature. But anywhere from the cardia, the entire stomach, antral, pyloric, it can arise from anywhere in the stomach. So back to our case, what did we do? We proceeded with surgery because the patient was symptomatizing with feeding intolerance and respiratory distress, midline expiratory incision. It was in fact exogastric. It was attached adherently to the transverse colon, to the diaphragm, and also, as we can see in this image, to the liver, which is retracted on the right side. Successfully, we could excise it all and with a part of the stomach, and we closed the stomach later with 2 layers. The pathology of our case turned out to be an immature grade 3 teratoma with free surgical margins. So the follow-up of our case after 3 months, he is healthy, he's at home, he is adequately feeding, he has gained weight. His follow-up ultrasonography is free, and also his alpha-fetoprotein is within normal range. Another rather interesting case that we had in our surgical ICU in the past few months was a case of post-corrosive esophageal stricture, for which we needed esophageal replacement, and we used a gastric tube to replace the esophagus. I'll be presenting the case. So our case was a 2.5-year-old male with history of corrosive ingestion, namely potash ingestion. We started him in our dilatation program, where we start dilatation starting 6 weeks after the ingestion with regular dilatations, and then we space them out gradually, guided by the symptoms of the patient. We almost always use adjunct treatment with dilatations, either steroid injection or mitomycin C application during the dilatation session. With this patient, we had used mitomycin C application on the stricture site. His stricture was 2 centimeters in length. He was actually improving on the dilatation program. He had absolute dysphagia before the dilatations, and throughout the program, his dysphagia was improving. But unfortunately, he dilated once elsewhere, and then a perforation occurred. It was managed conservatively, but this changed the game a bit for us. So this was his initial esophagogram, where we can see the stricture before the dilatations. This is when he presented to us after he had given the history of encountering a perforation. So as we can see, there is a perforation between the upper and the middle esophagus. As you can see here, the evidence of the perforation. So we took the decision, we need to replace the esophagus of this patient. Okay, so what are the different methods that we have to replace the esophagus? We have the most commonly used colon conduit. This is the most commonly used worldwide and the most commonly used in our department. Other options include a gastric tube, which we used for this case, gastric pull-up, and rarely we can use a jejunal interposition. So what are the differences between a colon interposition and a gastric tube? The colon interposition, as you can see on the left side, this was a different patient. We use the left colon or the transverse colon. We are dependent on the left colic artery, and we can use it to gap the bridge or replace the esophagus until the cervical part. Whereas in the gastric tube, we use part of the stomach, which is the part of the greater curvature of the stomach, dependent on the left gastroepiploic artery, also to form a tube and replace the esophagus. So what are the advantages and disadvantages quickly of each? A colon interposition, it's a straightforward procedure. It has a reliable blood supply. We can adjust the length as much as we want, and also it is the most commonly used in children, so we have the largest published studies about it in the literature. However, some of the disadvantages, first of all, we have 3 anastomosis. We have an oesophago-colic one, a gastrocolic one, a colocolic one. So we're following up a patient with 3 anastomosis. Also, by time, sometimes the esophagus becomes a bit redundant. Some stasis can occur over time. With the gastric tube, also the blood supply is reliable. We can also use it to bridge a long gap. It is less prone to this redundancy that sometimes occurs with the colon, and it is resistant to ulceration because it is the stomach. The disadvantages could be that we have a very long suture line, and the suture line is within the mediastinum, so it's a bit worrying for us. And also we reduce the stomach capacity because we have used part of it for forming the tube. As for the complications, it's somewhat equal. The colonic interposition and the gastric tube both have a mortality rate of 1 to 5%. The gastric tube has a slightly higher rate of leakage, 44% compared to the colon from 7 to 29. A higher percentage of stricture in gastric tubes was described more than in colon interposition, which was only 11 to 28%. Okay. So for our case, we decided to go for a gastric tube this time. First of all, we went with a thoracoscopy to perform esophagectomy and excision of this esophagus. Of course, it was very challenging because there were so many adhesions due to the previous present perforation. And what happened then was that there was a thoracic duct injury, but we did not know it at the time. We knew it later on, as we are going to say in our post-operative sequelae. Why did we remove the esophagus? It's advised that if we can, to remove the esophagus, because those with corrosive ingestions, they have a potential of malignancy higher than the rest of the population. Also because if we leave it, sometimes it could lead to a mucocele, and it's better to remove it if we can. And then we did an abdominal midline incision. Okay, and then we, as you can see here, this is the stomach. We inserted a 24 size Foley's catheter along the greater curvature. As you can see, this is the caliber of the gastric tube that we are aiming at. We then used the stapler to both divide and seal the part between the gastric tube and the rest of the stomach. As you can see here, we are cutting, and then we take it up to the chest, make sure that the length is adequate. It's going to reach the cervical esophagus. The vascularity looks good. We can do our anastomosis, our cervical anastomosis with a neck incision with the cervical esophagus. Okay. So, what happened next? Amru will give us an insight on the post-operative sequelae.
Post-operative, the patient was presented to us, intubated, was successfully extubated after 24 hours. Patient chest condition usually improves with nebulization and minimal suction, but he developed right side decrease in air entry with minimal collection noted on the X-ray, with serious output from intercostal tube. Once started oral intake, chylus output from intercostal tube analysis and CT confirmed chylus content and thoracic duct injury. According to the GIT consultation, patient started monogen with diet modification to be high protein, low fat diet, but unfortunately he didn't improve. Then the patient started send immune infusion, yet with no significant results. Finally, the patient was MPO for around 25 days and intercostal tube was repositioned to drain the posterior persistent collections. Patient intercostal tube output greatly improved upon the onset of oral intake and chest condition improved clinically and radiologically. This would show the fusion on the right side, the X-ray and the CT. Swallowing up to solids, according to the follow-up, swallowing up to solids with no dysphagia and clinically clear chest. This is the nearest contrast study done for the patient, showed good caliber for the gastric tube. And finally, the patient was discharged after 60 days in the ICU. Thanks to the pediatric surgery team, and thanks for us.